Stephanie Huff, and I am recording a concept on perfusion. This one is on shock. So an overview of shock, if this is characterized by a decrease in blood flow resulting in an inadequate oxygenation to the body organs and tissues. This causes life-threatening cellular dysfunction. In healthy individuals, homeostatic regulation depends upon several things. It depends upon sufficient cardiac output to meet bodily requirements. Depends upon uncompromised vascular system with good tone, so it can constrict and dilate to maintain normal pressures. It also depends on a sufficient blood pressure. Blood pressure and blood volume are needed to maintain blood flow. Tissues that can extract and use oxygen delivered through the capillaries is also necessary. Looking at basic hemodynamics, stroke volume is the amount of blood pumped into the aorta with each contraction of the left ventricle. Cardiac output is the amount of blood that is pumped per minute into the aorta by the left ventricle. It is determined by multiplying your stroke volume by the heart rate, and that will get you cardiac output. Your mean arterial pressure is the average pressure in the arterial circulation throughout the cardiac cycle. It is the product of cardiac output and systemic vascular resistance. So when cardiac output and systemic vascular resistance or total volume rises, the mean arterial pressure and tissue perfusion increases. Conversely, when cardiac output and systemic vascular resistance or total blood volume falls, then your mean arterial pressure and tissue perfusion will decrease. Sympathetic nervous system maintains the smooth muscle surrounding the arteries and arterioles in a state of partial contraction. This is known as sympathetic tone. Increased sympathetic stimulation will increase vasoconstriction and systemic vascular resistance. A decreased sympathetic stimulation allows vasodilation, which decreases the systemic vascular resistance. Pulse pressure is the difference between systolic and diastolic blood pressure. It is often an early indicator of shock. A narrowing pulse pressure is consistent with hypovolemic and cardiogenic shock as a result of reduced cardiac output. Septic shock causes a widening in the pulse pressure. Looking at the pathophysiology, hemodynamic properties are altered when one or more cardiovascular components don't function properly. Tissue perfusion is inadequate to sustain normal cellular metabolism. These are triggered by a sustained drop in the mean arterial pressure. This is caused by a decrease in cardiac output, decrease in circulating blood volume, or an increase in the size of the vascular bed as a result of peripheral vasodilation. And so all of these are things that occur in shock. Alright, so there are different stages of shock. The first stage of shock is stage 1. It is also known as early, reversible, and compensatory shock. It begins when baroreceptors detect a sustained drop in their MAP of 10 millimeters per mercury of normal levels and fluid losses of 25 to 35%. This causes the sympathetic nervous system to increase the heart rate and the force of cardiac contraction. thus increasing cardiac output. Vasodilation occurs, maintaining perfusion of cells, tissues, and organs. Symptoms in stage 1 are almost always imperceptible. The pulse is slightly elevated. Compensatory shock begins after the map falls 10 to 15 millimeters per mercury or below the normal. Compensatory mechanisms are short-acting, so they can only maintain the map for a short period of time. If effective treatment is provided, then the process is stopped at this point and there's no permanent damage. If there's no treatment, then compensatory mechanisms become harmful and shock perpetuates shock. All right, looking at stage 2. It is also called immediate or progressive shock. This stage occurs after a sustained decrease of MAP of 20 millimeters per mercury. So you can see how it's getting worse and worse as the shock state continues. They may also have a fluid loss of 35 to 50% at this stage. The compensatory mechanisms are still activated at this point, but they are unable to maintain the MAP enough to ensure perfusion of the vital organs. The cells will switch to anaerobic metabolism, so that's without oxygen. This causes lactic acid formation, which contributes to their acidotic state. The sodium-potassium pump fails due to no energy, causing sodium and water to move into the cells and potassium to move out of the cells. This causes the cells to swell because you have more sodium and water inside of them. The heart rate and vasoconstriction increases. The perfusion of organs, this includes skin, skeletal muscles, kidneys, GI organs. This perfusion decreases to those organs. The cells in the heart and brain become hypoxic. They will have a generalized acidosis and hyperkalemia, because remember the potassium has moved out of the cells, so now it's in the circulation. Unless treatment is rapidly started at this point, then the patient's survival is very poor. In stage 3 of shock, it is also known as refractory or irreversible shock. During this stage, there is a generalized tissue anoxia, so basically without oxygen. And this becomes so generalized and widespread that it causes widespread cellular death, that no treatment can reverse the damage at this point. The death of the cells, followed by death of tissues, results in death of organs, and then ultimately the death of the body. No treatments can reverse the damage done at this stage. All right, and so this is when you can see how they have the decreased perfusion to the periphery, and it causes their fingers to turn black due to lack of perfusion. So effects of shock on the body systems. Shock can produce predictable effects on different organ systems. So in the cardiovascular system, early on in shock, so this is in stage 1, they don't really have any changes. In progressive stage, which is stage 2, they have a slightly increase in blood pressure and heart rate. So they'll develop sinus tachycardia on the monitor. Their pulses may be thready. Late in shock, so this is stage 3, Their mean arterial pressure is less than 60 millimeters per mercury. They have a steadily decrease in their blood pressure as well as cardiac output. Their pulses are now imperceptible, so they're almost basically non-palpable. In the respiratory system, you will see an increased respiratory rate, respiratory acidosis. Potential complications are going to be ARDS, which is your acute respiratory distress disorder. In the gastrointestinal system, early on, you will have decreased GI motility. Late, you will have paralytic ileus. And so paralytic ileus is basically when the bowels are not moving at all and you don't hear any bowel sounds. Treatment of that is with an NG tube to suction. They may also have ulcerations of the GI mucosa. Potential complications are going to be bowel necrosis, neurologic manifestations. You will see decreased cognition, decreased sympathetic activity, and decreased consciousness. Early in shock, it may portray as restlessness and apathy. In progressive shock, it is related as lethargy, and in late shock, it is coma. Your renal system. Early on, you will have decreased renal perfusion and decreased glomerular filtration rate. Later on, they will develop oliguria. Potential complications are acute tubular necrosis and kidney failure. Your hepatic system, early on, you will have increased glucose production. During progressive stage, you have a decreased glucose production, which results in hypoglycemia. You have decreased lactic acid conversion, resulting in metabolic acidosis. Potential complication is destruction of the Kupffer cells, and this will end up with a systemic bacterial infections. When you're looking at the integumentary system or your skin, their skin is going to show pallor in the skin, lips, oral mucosa, nail beds, and conjunctiva. Their skin will also be cool and moist. Later on, in late shock, they will start to develop edema. Looking at temperature, their temperature is often decreased. They usually develop thirst. Looking at the etiology, it is identified according to the underlying cause, and so basically there are different types of shock. Hypovolemic shock is going to be the most common type of shock. It is characterized by a decrease in intravascular volume of greater than or equal to 15% that is lost. They will have decrease in blood return to the heart, as well as a loss of blood volume. This could be from hemorrhage, surgery, trauma, burns, severe dehydration, severe nausea, vomiting, diabetes insipidus, diuretics, and third spacing. As well as on your hypovolemic shock, for your cardiogenic shock, this occurs when the heart's pumping ability is compromised to the point that it cannot maintain the cardiac output and adequate tissue perfusion. Causes of loss of function include MIs, cardiac tamponade, restrictive pericarditis, cardiac arrest, dysrhythmias, especially fibrillation and ventricular tachycardia, pathological changes in the valves of the heart, cardiomyopathies from hypertension, alcohol, bacterial, or viral infections, or from ischemia. Could be from complications of a cardiac surgery. Drugs that affect the cardiac muscle contractility are also causes. Head injuries that cause damage to the cardiorregulatory system. Also electrolyte imbalances, especially changes in the normal potassium and calcium levels. A decrease in cardiac output leads to a decrease in the MAP. Heart rate may increase to try to compensate. You will also see JVD. Cyanosis is more common in cardiogenic shock than it is in some of your other shocks. Right, looking at obstructive shock. This is caused by an obstruction in the heart or great vessels that impedes venous return or prevents effective cardiac pumping action. Causes of obstructed shock are impaired diastolic filling, pericardial tamponade, or a pneumothorax. Increased ventricular afterload is usually from a PE. Increase in left ventricular afterload is usually from aortic stenosis or abdominal distension. Signs and symptoms of obstructive shock are the result of decreased cardiac output and blood pressure with reduced tissue perfusion and cellular metabolism. Distributive shock is also called vasogenic shock, and it includes several different types of shock that result from widespread vasodilation and decreased peripheral vascular resistance. Septic shock is also known as septicemia. It is the leading cause of death in clients in the ICU setting. It's part of a progressive syndrome called systemic inflammatory response syndrome, also known as SIRS. Neurogenic shock is the result of an imbalance between the parasympathetic and the sympathetic stimulation of vascular smooth muscle. If overstimulation or understimulation persist, then you will have a sustained vasodilation. Once this occurs, the blood will pool in the venous and capillary beds. They have a dramatic reduction in the systemic peripheral vascular resistance as the size of the vascular compartment increases. Causes of neurogenic shock could be head injuries, trauma to the spinal cord, insulin reactions like hypoglycemia, your CNS depressant medications, anesthesia, severe pain, and prolonged heat exposure. Signs and symptoms may early on they will have bradycardia, then it will turn into tachycardia as compensatory mechanisms are initiated. The CVP will drop as the veins dilate. Venous return to the heart decreases, stroke volume decreases, and their MAP falls. Anaphylactic shock is the result of a widespread hypersensitivity reaction, and that's usually anaphylaxis. This causes vasodilation, pooling of the blood in the periphery, hypovolemia with alterations in cellular metabolism, and this will occur with contact with an allergen that they have a hypersensitivity to. Risk factors for the development of shock. You have advancing cardiac disease. If they have that, they will have an increased risk for the development of cardiogenic shock. High risk behaviors like driving under the influence, participating in dangerous sports, increases the risk of trauma and shock due to bleeding or multi-system injuries. Diseases that slow the body's ability to clot are also risk factors. So patients that have hemophilia are going to be at risk for hemorrhagic shock, which also falls into hypovolemic shock. Your clinical manifestations, the onset can be rapid or slow depending on the cause and severity. Signs of early shock may be nonspecific. So as the body compensates, signs include tachycardia, and so the body is compensating basically for that hypotension and decreased blood volume. They also have decreased urinary output as well as tachycardia and tachypnea. They may also be diaphoretic. If treatment is not begun in the early stages, then the condition progresses and can't compensate anymore. Then you end up with a drop in their systolic blood pressure. You'll have a narrowing pulse pressure. They will have decreased LOC caused by a reduction of the cerebral blood flow. If shock is not reversed, cardiopulmonary failure will occur. Each type of shock has its own specific manifestations as well. And there's a good chart in your book from 1225 to 1227 on that. So for your hypovolemic shock, the initial stage, blood pressure is normal to slightly decreased. Pulse is slightly increased from the baseline. Respirations are usually normal. Skin is cool, pale in the periphery, and moist. Mental status, they're alert and oriented. Urine output may have a slight decrease. Other things, they'll have a decreased capillary refill time and they will be thirsty. During the compensatory and progressive stages, blood pressure, they will have hypotension. They will have a rapid thready pulse. Respirations are increased. The skin is cool and pale. Now it includes the trunk and not just the periphery. They have poor skin turgor with fluid loss. They start to develop edema with the fluid shifts. Their mental status, they may be restless, anxious, confused, or agitated. Urine output is oliguria, so it's less than 30 milliliters an hour. Other things, they have a marked thirst, acidosis, hyperkalemia, decreased capillary refill time, decreased or absent peripheral pulses. In the irreversible stage, the blood pressure is severely hypotensive. The systolic pressure is often less than 80 millimeters per mercury. Pulse is very rapid and weak. Respirations are rapid, shallow. You will hear crackles and wheezes on auscultation of the lungs. The skin is cool, pale, mottled with cyanosis. Their mental status is disoriented, lethargic, and comatose. Now they have anuria, so they don't have any urine output. Other findings are loss of reflexes, decreased or absent peripheral pulses. For cardiogenic shock, they will be hypotensive. Their pulse is rapid, thready. They have distension of veins of the hands and neck. Respirations are increased and labored. You will hear crackles and wheezes on auscultation. Pulmonary edema is common. The skin is pale, cyanotic, cold, and moist. Mental status, they are restless, anxious, lethargic. This will progress to a comatose state. Urine output, oliguria to anuria. Other things, you will see dependent edema, elevated CVP, elevated pulmonary capillary wedge pressure, and dysrhythmias. For your obstructive shock, signs and symptoms, tachycardia, tachypnea, hypotension, delayed capillary refill in the extremities, decreased urinary output, and peripheral edema. Distributive shock, tachycardia, tachypnea, hypotension, delayed capillary refill in extremities, decreased urinary output, peripheral edema, and absent or weak pulses. And so you can see how those are very similar to obstructive shock. Your septic shock, early signs of septic shock is also known as warm shock. Blood pressure is normal to hypotensive. Their pulse is increased and thready. Respirations are rapid and deep. Skin is warm and flushed. Mental status, they are alert, oriented, and anxious. Urine output is normal. Other, you will see an increased body temperature, chills, weakness, nausea, vomiting, diarrhea, and a decreased CVP. Late septic shock is also known as cold shock. Their blood pressure is hypotensive. Pulse is tachycardic with arrhythmias. Respirations are rapid, shallow, and dyspneic. Skin is cool, pale, and edematous. Mental status is lethargy to comatose state. Urine output, oliguria to anuria. Other findings, normal to decreased body temperature and decreased CVP. Normal neurogenic shock, they will be hypotensive. Pulse is slow and bounding. Respirations will vary. Skin is warm and dry. Mental status, they are anxious, restless, lethargic. This progresses to comatose states. Urine output, oliguria to anuria. They will also have a lower body temperature. For anaphylactic shock, they will be hypotensive. Their heart rate is increased. You will see dysrhythmias. Respirations, they will have dyspnea, stridor, wheezes, laryngospasms, bronchospasms, pulmonary edema. Skin is warm, edematous, around the lips, eyelids, tongue, hands, feet, and genitals. Mental status, they are restless, anxious, lethargic to comatose. Urine output is oliguria to anuria. Others, you may see paresthesias, pruritus, which is your itching, abdominal cramps, vomiting, and diarrhea. Collaboration. It is important to treat the underlying cause of the shock. You want to increase their arterial oxygenation and improve tissue perfusion. The first course of collaborative action to arrest shock is going to include emergency care. These measures include oxygen therapy, fluid replacement, and medications. All right, so diagnostic tests that are done. They will do blood hemoglobin and hematocrit. Changes to these concentrations usually occur in hypovolemic shock. And that's just due to fluid and blood loss. Your arterial blood gases are done to determine oxygen and carbon dioxide levels as well as pH. The effects of shock and the body's compensatory mechanisms can cause a decrease in pH, and that puts them in that acidotic state. They may have a decrease in PaO2 and in the total oxygen saturation and an increase in their PaCO2. Serum electrolytes are done to monitor the severity and progression of shock. So as shock progresses, the glucose levels will decrease, sodium levels decrease, and the potassium levels will increase. So those are specific things you're looking for. Your blood urea nitrogen, your BUN, creatinine levels, urine specific gravity, and osmolality is done to check renal function. As perfusion to the kidneys is decreased and renal function is reduced, then your BUN and creatinine levels will increase. So will your urine specific gravity as well as urine osmolality. White blood cell count and blood cultures are done to identify the causative organs in septic shock. Your white blood cells with differential these are done in a client with septic and anaphylactic shock. The total white blood cell count will be increased in septic shock. They will have elevated neutrophils that indicate an acute infection. Increased monocytes indicate a bacterial infection. and increased eosinophil indicate an allergic response that you will see in anaphylactic shock. Your serum cardiac enzymes are elevated in cardiogenic shock. Your central venous catheterization is to aid in the differential diagnosis of shock, and it does provide information about the preload of the heart. So other diagnostic tests that can be done to determine the extent of the injury or damage or to locate a site of internal hemorrhage could be an endoscopic exam or an echocardiogram. All right, looking at pharmacology therapy. All right, so the vasoconstrictors and your inotropes, those fall into a class of adrenergics. Your vasoconstrictors will help increase venous return. Norepinephrine, which is also Levophed, and your metaraminol are examples of vasoconstrictors. Your inotropes will help improve cardiac contractility. Dopamine, dobutamine, and isoproterenol are examples of that. So your adrenergic drugs, they are also called sympathomedics. They mimic the fight or flight response of the CNS. The physiologic effect of these drugs include improved perfusion and oxygenation of the heart with increased stroke volume and heart rate and increased cardiac output. All right, your vasodilators. Examples of these are your nitroglycerin and nitroprusside. These drugs cause vasodilation and act directly on smooth muscle, affecting both arterioles and veins. And these effects decrease the oxygen need of the heart, decrease pulmonary congestion. Vasodilators are used primarily in the treatment of cardiogenic shock and may be combined with the use of dopamine as well. All right, other drugs that are used. Diuretics are used to increase urinary output after fluid replacement is initiated. That keeps them from going into fluid overload. Your sodium bicarbonate is used to treat the acidosis because it's a buffer. Your antidysrhythmic agents are used to stabilize the heart rhythm. Antibiotics are used to treat septic shock. Calcium is used to replace the lost calcium from blood transfusions. Morphine is given, it helps to dilate the veins as well as decrease anxiety. Your epinephrine and histamines and inhaled beta-2 agonist. Corticosteroids are used to treat anaphylactic shock. Cardiotonic glycoside, which is digitalis, is used to treat cardiac failure. Oxygen therapy. All clients with shock, even those that have adequate respiration, should receive oxygen therapy via mask or nasal cannula to maintain their PaO2 of greater than 80 millimeters per mercury during the first 4 to 6 hours of care. If they can't maintain their PaCO2 with unassisted respirations, then ventilatory assistance may be needed. Fluid replacement therapy. This is the most effective treatment for hypovolemic shock, is to administer IV fluids or blood. Fluids are also used to treat neurogenic and septic shock. Patients in cardiogenic shock may need fluid replacement or restriction depending on their pulmonary artery pressures. Fluids can be administered alone or in combination through 2 large bore IVs or a central line. Your crystalloid solutions and your colloid solutions are given to increase circulating blood volume and tissue perfusion. Your crystalloids can either be isotonic or hypotonic, and they can contain dextrose or electrolytes dissolved in water. It is potential for peripheral edema. With use of these, so you have to be very careful when you're using those and monitor your patient carefully. Your lactated ringers and normal saline are fluids of choice to treat hypovolemic shock. Your colloids, these are substances that should not diffuse through the capillary walls, so basically they remain in the vascular system and help to increase the plasma volume. Whole blood or blood products can be given to increase the oxygen carrying capacity of the blood and also increase oxygenation of the cells. These products are used for hemorrhaging. Looking at the nursing process, priority nursing care requires a very rapid assessment and reaction to subtle symptoms to prevent a downward cascade of events. The nurse should anticipate potential for shock so that they can promote rapid interventions. So they should always be looking for signs and symptoms so interventions can be started quickly. Looking at the assessment for hypovolemic shock, remember this is the most common type of shock. Some of your most common causes of hypovolemic shock can be recent surgeries, multiple traumatic injuries, or burns that can lead to the development of hypovolemic shock. With these, you want to monitor fluid status, assess your patient's weight, their fluid intake, all their measurable fluid losses. So that may be from urine, vomit, wound drainage, gastric drainage, chest tube drainage. So whatever kind of drains they have coming out, you want to make sure that you're assessing all of those. Cardiogenic shock, patients with left and anterior wall MI are at risk for developing cardiogenic shock. Nursing care to prevent cardiogenic shock is going to be to maintain or improve myocardial oxygen supply by providing immediate pain relief, maintaining rest, and administering supplemental oxygen. Your neurogenic shock is increased in patients who have spinal cord injuries or have received spinal anesthesia. Preventative care is to maintain immobility with spinal cord trauma and the head of the bed elevated 15 to 20 degrees after spinal anesthesia. Any higher than 20 degrees can precipitate a spinal headache, and so it should be avoided. For anaphylactic shock, this is usually related to allergies. That could be to food, could be from drug reactions. They can also have serious reactions that develop an anaphylactic shock with blood or blood product infusions. So nurses can prevent by collecting information about the patient's allergies, any kind of drug interactions they've had in the past, and documenting these in their chart and placing a special armband on the patient, letting everyone know that they do have allergies. Septic shock, patients that are chronically ill and debilitated are going to be at risk for septic shock. Also, patients that have had invasive procedures or tube insertions are going to be at risk. Nursing care to prevent septic shock is going to include careful and consistent hand washing, use of aseptic technique for procedures such as catheterizations, suctioning, changing dressings, starting and maintaining IV fluids or medications. You want to monitor for local and systemic manifestations of infection. So looking at their white blood cells with differentials. And that will tell you more about systemic. Diagnosis. These are your NANDA diagnoses for shock. In planning, goals may include that the client will maintain airway, breathing, and circulation. They will maintain perfusion to meet body needs, understand all their procedures. They will verbalize feelings to reduce anxiety. Cardiac workload will also be reduced. In implementation, in preserving cardiac output, you want to assess and monitor the cardiovascular function. This is going to include monitoring blood pressure, heart rate and rhythm, pulse oximetry, peripheral pulses, and hemodynamic monitoring. Measure their intake and output, because remember they're at risk for renal failure due to hypotension and the effects of the compensatory mechanisms on the kidneys. Urinary output should be at least 30 milliliters an hour. Preserving cardiac output continued. You want to monitor bowel sounds and abdominal distension, as well as abdominal pain. They are at risk for paralytic ileus. You want to monitor for sudden sharp chest pain. Monitor for dyspnea, cyanosis, anxiety, restlessness. They are at risk for PEs, and that is related to hemoconcentration and increased platelet aggregation. You want to maintain bed rest and provide a quiet, calm environment. Usually you'll put the patient in a supine position with the legs elevated about 20 degrees, with the trunk flat and the head and shoulders elevated higher than the chest, about 10 degrees. It's kind of like a modified Trendelenburg. They do not recommend doing Trendelenburg position any longer, because the abdominal organs can press against the diaphragm, and that limits respiratory respirations. It also decreases the filling of the coronary arteries and initiates aortic and sinus reflexes. With them laying supine with their legs elevated, that will increase venous return. This position is not used in cardiogenic shock though, but it can be used in the other types of shock. Limiting activity and ensuring rest will decrease the workload of the heart. Promoting tissue perfusion. You want to monitor the skin for color, temperature, turgor, and moisture. Decreased tissue perfusion is evident by the skin being pale, cool, and moist. As the hemoglobin concentration decreases, then cyanosis can occur, and that's what you see in cardiogenic shock. You want to monitor cardiopulmonary functioning by assessing and monitoring their blood pressure by auscultation or hemodynamic monitoring. You want to monitor the rate and depth of respirations, lung sounds, pulse oximetry, peripheral pulses, looking at brachial, radial, dorsalis pedis, and posterior tibial. If you can't palpate a pulse, then obviously you will get a Doppler. You want to also include, when you're palpating and assessing pulses, you also want to include the presence of the pulse, the quality of them, so are they equal on both sides, the rate, rhythm, and quality. You also want to assess for JVD as well as CVP measurements. Monitoring body temperature. An increased body temperature increases metabolic demands and depletes energy reserves. It increases myocardial oxygen demand as well. You want to monitor urine output per Foley catheter with hourly measurements using a urometer. Urine output is a reliable indicator of renal perfusion. Also want to assess mental status and level of consciousness. This helps to determine adequacy of cerebral circulation. Restlessness and anxiety are common in early shock. In later stages, they may become lethargic and progress to a comatose state. Alterations in level of consciousness result due to cerebral hypoxia and the effects of acidosis on the brain cells. Relieving anxiety. You want to assess for the causes of anxiety. You want to provide periods of rest, reduce stimulation that causes anxiety, and that will help calm the patient and facilitate rest. You want to administer pain medication on a regular basis because pain can increase anxiety. Increase their comfort and reduce restlessness by maintaining a clean environment. Provide skin and oral care. Monitor the effectiveness of ventilation and oxygen therapy. You want to speak slowly and calmly using short sentences. Stay with the patient during procedures and use touch to provide support. Providing client and family support. You want to provide time, space, and privacy for the family. You want to allow the family to visit with the patient when it's feasible. You want to encourage family and the client both to express any concerns or feelings they have and acknowledge their beliefs, values, and expectations concerning their shock state. You also want to provide information about current settings to the client and family and let them know any available resources. So pastoral care, social services, temporary housing, and meals, let them know those are available. In evaluation, your expected outcomes may include that the client does not progress to an uncompensated shock, and that was the last stage of shock, and the family copes with the stress of the client's injury. So this is the end of shock, and as always, if you have questions, let me know and I will try to help clarify.